Good afternoon, everyone, and welcome to the Healthy People 2030 Spotlight on Health webinar. So today we'll be covering best practices in chronic pain management. So we're glad that you're here to join us today as we discuss this important topic. So next slide, please. So I'm Carter Blakey, the Deputy Director of the Office of Disease Prevention and Health Promotion in the U.S. Department of Health and Human Services. Today, I'll share key highlights in the Healthy People 2030 initiative and review the latest data for the chronic pain objective in Healthy People 2030. And now I'm happy to introduce our speakers for today. So we have Dr. Richard Nahan, who is the lead epidemiologist at the National Center for Complementary and Integrative Health at the National Institutes of Health. So Richard will review the epidemiology of chronic pain, including comparing the burden and the cost of pain with other chronic conditions. Next, we'll have Christina Mikus, who is the lead medical officer in the Division of Overdose Prevention within the Centers for Disease Control and Prevention. She will review the 2022 CDC Clinical Practice Guideline for prescribing opioids for pain. So next slide, please. Dr. Scott Lawrence, who's the acting senior policy advisor in the Eye Quality Improvement and Innovations Group at the Centers for Medicare and Medicaid Services, will present on chronic pain management treatment services. We have Cindy Steinberg, who's the Director of Policy and Advocacy with the U.S. Pain Foundation, which is, by the way, a Healthy People champion. She will detail the keys to successful chronic pain management, including findings from the HHS Pain Management Best Practices Interagency Task Force. Then following the presentations, we'll have a moderated discussion. And along with our presenters, June Oliver, the president-elect of the American Society for Pain Management Nursing, and Francis Narek, president of the Coalition for Registration of Exercise Professional, who's another Healthy People 2030 champion. They will both share their perspectives and answer your questions. So next slide, please. So what is Healthy People? So over the past 40 years, the Healthy People Initiative has established data-driven national objectives with 10-year targets to improve the health and well-being of the nation. Healthy People is grounded in the principle that establishing objectives and providing benchmarks to track and monitor progress over time can motivate, guide, and focus action. It underpins priorities and strategic initiatives and provides a framework for prevention and wellness programs for a diverse array of both federal and non-federal users. Then beyond the federal government, Healthy People is used by state and local health officials, community health advocates, non-governmental organizations, researchers, academia, and even businesses, all of whom seek to improve the health of their own constituent populations and address the social determinants of health and advance health equity. And to give you just a few examples of how Healthy People is put into practice, it's used as a model for state health improvement plans and community health assessments. It's a resource for securing public health accreditation, metrics for measuring program performance, and other countries have used Healthy People as a model for their own disease prevention and health promotion plans. And this decade's initiative, Healthy People 2030, which is actually the fifth iteration, builds on the knowledge gained over the past 4 decades. So next slide, please. So as shown on this slide, Healthy People 2030 is composed of several unique elements that complement one another and are designed to collectively influence progress toward achieving the Healthy People 2030 vision, which is a society in which all people can achieve their full potential for health and well-being across the lifespan. So these elements, as depicted on the slide, include the overall health and well-being measures, our 3 categories of national objectives, which are the core or measurable objectives, developmental objectives, and research objectives. And then also we have the leading health indicators, which are a small subset of those core objectives. So next slide, please. So I think we all recognize that the efforts required to eliminate health disparities and achieve health equity extend well beyond simply promoting healthy choices. The social determinants of health, or SDOH, which have become so vitally important to achieving the healthy people goals and objectives, are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So the Healthy People 2030 SDOH framework, which is conceptualized in this slide, identifies 5 key domains that influence health, and those are economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community contacts. And each of these domains reflects a number of critical underlying factors that impact the social determinants of health. So next slide, please. So now I'll turn to the chronic pain objective that we have in Healthy People 2030. So this objective tracks adults with high impact chronic pain, which is defined as pain experienced on most days or every day in the past 3 months. And the pain is accompanied by a limitation in life or work activities. So high impact chronic pain is tracked using data from the National Health Interview Survey. And although we did have this objective in Healthy People 2020, the last decade's Healthy People iteration, due to the 2019 redesign of the National Health Interview Survey, that Healthy People 2020 objective and Healthy People 2030 objective are not comparable. So this decade, data are expected to be available from the NHIS biennially. So in the next 2 slides, we'll take a closer look at some of the data by selected demographic groups for the baseline year of 2019 and the most recent data point, which is 2021. So next slide, please. So this slide shows the proportion of adults with high impact chronic pain for the total population and for subpopulations by sex, race, ethnicity, and age in 2019 and 2021. And the percentage of adults with high impact chronic pain decreased by 7.2% from 6.9% in 2019 to 6.4% in 2021. Then between 2019 and 2021, the percentage of adults with high impact chronic pain decreased for females, white adults, and those aged 18 to 44, and then also for those 65 years and older. And I'll note that there was no significant difference between 2019 and 2021 estimates for all of the other groups that are shown on the slide. So next slide, please. Now this slide shows the proportion of adults with high impact chronic pain for the total population and for subgroups by educational attainment, family income, disability, and veteran status in 2021. So adults with less than high school education, those with a high school education, and those with some college were all more than twice as likely to report high impact chronic pain than adults with a 4-year college degree or more. Then adults with family incomes below the poverty threshold were 4 times more likely to report high impact chronic pain than those with incomes of 400% or more above the poverty threshold. So that those totals would have been 14.3% versus 3.8%. Then compared to their counterparts, high impact chronic pain was higher among adults with disabilities and veterans. So note that the high impact chronic pain for adults with disabilities was about 7.5 that for adults without disability. So this represents the largest disparities shown today. So with that overview of the Healthy People 2030 initiative and the data on our chronic pain objective, I'm going to turn the webinar now over to Richard from NIH. So Richard, it's all yours.
Thank you for the introduction. I am Richard Nayan. I'm with the National Center for Complementary Integrative Health, as you just heard. And I'm going to tell you about the burden of pain in the United States. Next slide, please. So before I can go any further, I have to acknowledge my collaborators without whom this talk would not be possible. Next slide. So I'm going to be covering two really separate topics. One is looking at pain's one-year trajectory, and the other is to look at pain's burden compared to other chronic health conditions. Next slide, please. So we just heard from Deputy Director Blakely the prevalence of chronic pain and high-impact chronic pain in U.S. adults. Now, as many of you may be aware, prevalence data cannot distinguish between existing cases of chronic pain and new cases known as incident pain. Now, incidence data are critical as they provide the rate at which new cases enter into the U.S. population. And in order to separate out new cases from existing cases, we need to follow survey participants over time. Next, please. So in order to do that, I'm going to be using the National Health Interview Survey longitudinal cohort. It followed 10,415 people from 2019 to 2020. This was recently published in JAMA Network. Next, please. So in this slide, I'm showing the pain status of those in 2020 who were pain-free in 2019. Again, I'm following people over time. On the x-axis, you can see we're looking at 4 markers for pain status: no pain, non-chronic pain, or those individuals who said they had pain sometime in the last 3 months. Chronic pain and then high-impact chronic pain is already defined. Next slide, please. So for instance, of those people who were pain-free in 2019, 62% continued to be pain-free in 2020. Next, please. However, 30% of people had incident non-chronic pain. Again, this is just pain that is a short duration. Next, please. We see that 6.3% of these individuals had chronic pain and 1.4% had high-impact chronic pain. 1.4% is much lower than we just saw in the prevalence data. And that's, again, because this is only looking at new cases, while the prevalence data was looking at new and existing cases. Next, please. Now, of course, high-impact chronic pain is really just a component of chronic pain. Next, please. And so what we found here is that about 20% of people with chronic pain in this situation reported high-impact chronic pain. Next, please. And this is, again, remind you, these are all incidence measures here because the people were pain-free in the previous year. So if we were to total these up, we'd find that about 38% of the US population had some kind of incidence pain in the following year after they were pain-free. Next, please. So now we're going to look at those who had chronic pain in 2019 and their pain status in 2020. You can see the same pain status conditions are listed on the x-axis. Next, please. So here we're seeing that of those people who had chronic pain in 2019, 61.4% continued to have chronic pain in 2020. And we're labeling this group as having persistent chronic pain. Next, please. Now we're seeing a fairly high rate of high incidence chronic pain. 26.8% of the people who had chronic pain in 2019 report high impact chronic pain in 2020. Next, please. Now in this situation, high impact chronic pain comprises about 44% of all chronic pain individuals. So what we're, our take-home message from this is that the longer you have chronic pain, the more likely you are to, the longer you have chronic pain, the more likely you are to develop high-impact chronic pain. And next, please. So in these last 2 points, what we're seeing is that of those people who had chronic pain in 2019, 10.4% now reported no pain in 2020, while 26.6% reported non-chronic pain. Next, please. Now, these are both examples of recovery from chronic pain. Now, ideally, we would want everyone to recover fully to the no pain state, but clinically, a change from chronic pain to no chronic pain would be certainly clinically meaningful. Next, please. Now, another way to examine the burden of pain, besides simply looking at incidence and prevalence, is to compare chronic pain's burden to other chronic health conditions, such as diabetes or hypertension. The next slide. So in order to do that, we're going to be using data from the Medical Expenditure Panel Survey, or MEPS, as it's commonly called. MEPS is an annual survey done every year by the Agency for Healthcare Research and Quality, AHRQ, another component of DHHS. Now, unfortunately, MEPS does not contain the 2030 Healthy People Pain Questions. So instead, in this analysis, we're going to sort of estimate the amount of chronic pain by looking at chronic conditions that are generally associated with pain, such as osteoarthritis or back problems or lupus. And if you look at the y-axis here we're not presenting percentages, we're presenting frequency data, the number of people who have these health conditions in millions. And so you can see on the x-axis again, besides looking at chronic conditions with pain, we're looking at a number of chronic conditions that are not associated with pain, such as hypertension or heart disease. Next, please. Can you go 3 more? 1, 2, 3. Next one. One more. There. So this is showing the full range of frequencies for these diseases. You can see for kidney disease, only 6 million people reported kidney disease in 2020, while 10 times as many people, 62 million, reported hypertension. The bars in red indicate the painful health conditions, as might be obvious from the names. So you can see that of the painful health conditions, osteoarthritis is by far the highest at 44 million. And the frequency of osteoarthritis is much higher than the heart disease or diabetes. But of course, what Healthy People 2030 is really interested in is not individual health conditions for pain, but the gestalt of pain. So we can sort of estimate the gestalt if we simply added together the frequencies for these 4 health conditions. Next, please. If we do that, we find that the sum of this is 79 million people, which is higher than any of the other chronic conditions on the slide. But there are some caveats with this number. Next, please. The first caveat is this number, 79 million, assumes there's no comorbidity between the various pain measures. And we know that's not true. For instance, I just read a paper a couple of days ago that found that about 20% of people with osteoarthritis also reported back pain. So this comorbidity would tend to reduce the 79 million people downward. Next, please. On the other hand, this number of 79 million doesn't include a lot of other pretty common painful health conditions, such as rheumatoid arthritis or fibromyalgia, or actually neuropathic pain, which is its own condition. So many types of different neuropathic pain. So these, adding these would, of course, increase the 79 million upward. So from my point of view, if we balance the downward pull and the upward pull, these data, even though they're very, very preliminary, they do suggest to us that the gestalt of chronic pain is much more of a burden than these other chronic conditions. Next, please. Now, besides looking at prevalence data, which we were just looking at, we can also look at direct healthcare costs. So this slide is going to be organized the same. On the bottom of the slide, we're going to be showing the different painful health conditions and non-painful health conditions. But on the y-axis, notice we're now showing billions of dollars, because this is what we're going to be plotting here. The billions of dollars used for direct healthcare expenditures on these conditions. Can you go forward 2, please? 1, 2, there you go. So here we see the range again. You see on the low end headaches, which is really severe headaches and migraines, about $14 billion was spent in 2002 on these on this condition. On the other hand, about tenfold greater are mental health disorders, where 145 billion were spent in 2020. The rest of the conditions are in about the same ranking as we saw on the other side, except for hypertension. If you might recall, hypertension had the highest prevalence frequency in that slide previously, but here, in terms of healthcare costs, you can see it's towards the low end, and this is because most hypertension nowadays is treated with fairly inexpensive medications versus procedures and stuff. Next slide again. So here again, I've simply added together the costs associated with the 4 painful conditions, and now it's $232 billion. This is beginning to be real money even for the federal government. But again, we have our 2 caveats, 2 slides. Just go 1, 2, 1, 2, right. And so again, this is very preliminary data. We just started analyzing these expenditure data in MAPS. But if you take what we saw for the frequency data and what we're seeing for the healthcare data, to me, this is already compelling evidence that chronic pain's burden, the burden of chronic pain is much higher than for other chronic conditions. Next slide. So again, if you're interested in learning more what the NCCIH, National Center for Complementary Integrative Health Epidemiology Program does, you could email me. My email is nayanr@nih.gov. Or you can just go to our website, www.nccih.nih.gov. You could either type in pain into the search engine or epidemiology program, and you'll find a lot more about us. Thank you. So now I'm going to introduce Dr. Christina Meckes from the CDC. Thank you.
Great, thank you very much. I'm Christina Meckes. I work for the National Center for Injury Prevention and Control at CDC. And I'm really honored to have the opportunity today to spend a few minutes talking about the CDC Clinical Practice Guideline for prescribing opioids for pain. Next slide, please. I want to spend a moment just starting off my talk, talking a bit about how the CDC's guideline supports Healthy People 2030. CDC's mission overall is to protect the health, the well-being, and the lives of all Americans. And we care deeply about health, safety, and quality of life of patients that are living with pain. And we're committed to ensuring that patients get the best possible care. We know that pain, chronic pain, high-impact chronic pain, affects the lives of millions of Americans, and improving care for patients living with pain is a public health imperative. All patients with pain should have access to effective, safe, and sustainable pain treatment options. So to advance pain care in the US, CDC released recommendations for clinicians to provide pain care for adults, which can include prescribing opioids. The 2022 CDC Clinical Practice Guideline for prescribing opioids for pain aims to help clinicians work with their patients to provide the safest and most effective pain care possible. So clinicians can use this guideline to work together collaboratively with patients to help them set and achieve personal goals, to reduce their pain, to improve function, quality of life, and their ability to participate in life and work activities, all in line with Healthy People 2030 objectives. I'll also cover today, as outlined on this slide, a brief rationale for releasing the CDC Clinical Practice Guideline for prescribing opioids for pain, some clarification of what the guideline is and is not, an overview of what's different with the 2022 Clinical Practice Guideline compared to CDC's previous guideline from 2016, some overarching guiding principles to inform the implementation of the recommendations in the 2022 guideline, very brief, just for the sake of time, a very brief overview of the recommendation statements, and I'll just close with a resource for clinicians to help them incorporate the recommendations into clinical practice. Next slide, please. So first, why was the guideline updated? Why was the 2016 CDC guideline updated, and why release the 2022 Clinical Practice Guideline for prescribing opioids for pain? In 2016, when CDC published the CDC guideline for prescribing opioids for chronic pain, it was focused on recommendations for chronic pain treatment, specifically in outpatient settings. And at the time it was released, CDC had indicated the intent to reevaluate the guideline as new evidence became available, and to determine when that sufficient evidence was present to merit an update of the guideline. We know, as mentioned, that pain has affected the lives of millions of Americans. And despite this, we also know that many patients with pain aren't able to access the full range of potentially helpful therapies. In large part, this is due to limited access to treatment modalities and to a lack of clarity around the evidence supporting pain treatments. In addition, we know that where people live, what means they have, who they are can result in far less access to evidence-based pain care. We also know that opioids continue to be commonly used to treat pain. And so, as mentioned, there was new evidence that had surfaced in the time since the 2016 guideline was published that supported expanding guidance and specificity in an updated guideline. And this is the new information that helped prompt the expanded CDC guidance. Next slide, please. So a few words about what the 2022 CDC clinical practice guideline is. I want to emphasize a couple of important points. The guideline is a clinical tool. It's meant to assist and guide shared decision-making between clinicians and patients, to empower them to make person-centered decisions related to pain care together in a collaborative fashion. It's intended not just for primary care clinicians, but also for all clinicians that provide pain care, including those that prescribe opioids, specifically in an outpatient setting for patients who are 18 years and older. And I've defined the different types of pain that are covered in the 2022 guideline. There's acute pain, defined in the guideline as pain with a duration of less than 1 month, subacute pain with a duration of 1 to 3 months, chronic pain, which we define in the guidelines as pain with a duration of more than 3 months. But we all know that these durations to define acute, subacute, and chronic pain really imply more specificity than what we would see in real life. But there's a gradual transition potentially between acute and chronic pain. But we provided these definitions as a way to provide guides to facilitate the consideration of the recommendations in the guideline. I'll focus more on chronic pain for the duration of my talk. The guideline, is mentioned in the last bullet here, is that it is intended to be flexible to enable patient-centered decision-making. I really want to stress that point. We want to make sure that we're taking into account an individual's expected health outcomes and well-being in collaborative decisions that are made in the treatment of pain. Next slide, please. So a few words about what the guideline is not, and this is equally important as what I shared on the previous slide. It's not a replacement for clinical judgment, for understanding your patient, not a substitute for individualized, person-centered care. It's not intended to be applied as inflexible standards of care across patients, patient populations by all of the entities that I listed here: healthcare professionals, health systems, pharmacies, third-party payers, governmental jurisdictions, and it's not intended to lead to the rapid tapering or abrupt discontinuation of opioids for patients. It's not intended to be a law, a regulation, or a policy that dictates clinical practice, and it's not a substitute for FDA-approved labeling. It's not applicable to a number of certain clinical situations for which benefits of risks of pain management and the approach may differ, and for which other existing guidelines may apply. Specifically, the management of pain related to sickle cell disease, the management of cancer-related pain, and palliative care and end-of-life care. And the guidelines also not focused on opioids that are prescribed for opioid use disorder. Okay. Next slide, please. So what's different compared to the 2016 guideline? The 2022 CDC clinical practice guideline does have new expanded content that covers acute and subacute pain, as I mentioned previously. But as I said, I'm going to focus on what's different from the 2016 guideline as it relates to chronic pain for the remainder of my talk. Next slide, please. So specifically for chronic pain, what's different compared to 2016? We all know that patients with pain deserve treatment that provides the greatest benefits. And there is evidence that some non-opioid treatments, including therapies that don't involve medications at all, may actually work better for some conditions and have fewer risks and side effects. In the interest of time, I won't go through everything that's mentioned on this slide, but what I'm trying to depict and describe here is that there's updated content in the guideline that outlines benefits and risks of certain non-opioid pain treatments for certain chronic pain conditions. So back pain or osteoarthritis, neck pain, fibromyalgia, and neuropathic pain. Next slide, please. There's also expanded recommendations on tapering of opioids. We know that there's emerging data that highlights both benefits and risks of tapering opioids. And there's a new recommendation statement in the 2022 CDC clinical practice guideline that outlines in greater detail how clinicians can work with patients who are already receiving opioids to determine if and how to taper opioids. And it emphasizes 3 key principles that are outlined here on the slide. First, patient-centered treatment changes are paramount, using empathy and shared decision-making. Second, Slower tapers for better tolerability are necessary when patients have been taking opioids for longer durations of time. And third, avoiding abrupt discontinuation of opioid therapy or rapid reduction of opioid dosages. Next slide, please. I want to spend a moment talking about health disparities because this is an added focus of our 2022 CDC clinical practice guideline. It incorporates updated evidence on long-standing health disparities when it comes to the treatment of pain. We know, because there's a broad evidence base to support this, that there's racial and ethnic disparities in the delivery of care for pain. Black and Latino patients are less likely to receive analgesia for acute pain than are white patients. We know that there's geographic disparities as well in the treatment of pain. Adults living in rural areas are more likely to be prescribed opioids for chronic, non-malignant pain than adults that live in non-rural areas. And we know that there are disparities in treatment due to access and affordability. Multimodal therapies and approaches to treatment may not always be available to all patients or reimbursed by insurance. These are important considerations to keep in mind. Next slide, please. 2022 CDC Clinical Practice Guideline also has 5 overarching guiding principles to broadly inform the implementation of its recommendation statements. I'll go over these briefly. First, pain needs to be appropriately assessed and treated independent of whether opioids are part of that treatment regimen. Also, the recommendation statements in the guideline are voluntary. They're there and intended to support, not supplant, individualized person-centered care. Flexibility is so important. It's needed to meet the care needs and clinical circumstances of a specific patient treated as an individual. Also, multimodal and multidisciplinary approaches to pain management are really key in successful pain care. So what does that mean? It means attending to physical health, behavioral health, long-term services and supports, and taking into consideration expected health outcomes and well-being of each individual person. That's critical. Next slide, please. Special attention should be given to avoid misapplying the clinical practice guideline beyond its intended use, or implementing policies that were purportedly derived from it that might lead to unintended and potentially harmful consequences for patients. And lastly, vigilance is needed to attend to health equities and to ensure access to appropriate, affordable, and effective pain treatment for all persons. Next slide, please. In the interest of time, I can't walk through all 12 recommendation statements, but what I will do is talk about the 4 large areas that the recommendation statements fall into, and with some brief overarching principles within those 4 areas. So first, determining whether or not to initiate opioids. So some overarching themes here is that, of course, as mentioned, all patients with all types of pain, but especially including chronic pain, should receive treatment that provides the greatest benefits relative to risks. Before discussing or prescribing opioid therapy, clinicians should discuss with patients expected and realistic benefits and known risks of opioid therapy. And opioid therapy should be initiated with consideration by the clinician together with the patient of a strategy that could be used if that opioid therapy is not successful in improving pain and pain-related function. Next slide. Selecting opioids and determining opioid dosages. Appropriate selection and dosage of opioids are important factors when opioid therapy is prescribed as part of a pain management plan. And clinicians should discuss the benefits and risks of different types of opioids with patients. Next slide. Deciding duration of initial opioid prescription and conducting follow-up is the third main area. Clinicians should absolutely involve patients in decisions about opioid duration. They should regularly assess patients who are receiving ongoing opioid therapy. And during follow-up appointments, clinicians should discuss patient preference for continuation of opioid therapy. It's a collaborative decision. Next slide, please. And then lastly, assessing risk and addressing potential harms of opioid use. And some overarching themes here are that clinicians should evaluate and discuss the patient's risk for opioid-related harms before initiating opioid therapy, and assess those risk factors periodically with the frequency that's individualized to a patient, their comorbidities and their risk factors. And then creating a management plan that incorporates strategies to mitigate risk, and discontinuing opioids if the benefits no longer outweigh the risks. Again, a patient-centered decision on an individual level. Next slide, please. Then lastly, I just want to highlight the website here that links to some resources that are in ongoing development intended to help clinicians apply the recommendations and the guidance in the 2022 CDC Clinical Practice Guideline into practice. Recently released and posted at this link is a new online training that provides an overview of the recommendation statements in the 2022 CDC Clinical Practice Guideline, and that's linked to there on the slide. Next slide, please. And with that, I'll close. I really appreciate the opportunity to speak as part of this webinar today. And I'll now turn it over to Scott Lawrence with CMS. Thank you.
Hi, thank you very much. This is Scott Lawrence from the Centers for Medicare and Medicaid Services, or CMS. I recently joined the Quality Improvement and Innovations Group as a senior advisor, and I had previously worked in the area of CMS that is responsible for the physician's fee schedule, where we worked with colleagues across the agency to create and value payment for 2 new chronic pain management codes. We're very excited about these codes, and these will be the topic of my presentation today. Additionally, I continue to see patients who have conditions that cause pain as a doctor in private practice, and have done so for more than 30 years. Next slide, please. So this is our disclaimer slide. This basically says that the presentation was prepared as a tool and that it's a general summary. It's not meant to be law, or employees and agents and staff make no representations or warranties, but it is true to the best of our knowledge at the time of the presentation. Thank you, and moving to the next slide, please. So today's objectives are going to be to name the 2 healthcare procedural common system codes, healthcare common procedural coding system codes for chronic pain management and treatment services, and describe the elements of these HCPCS codes for potential use cases. Next slide, please. Medicare has not historically recognized a specifically team-based approach to pain management and treatment, including aspects such as person-centered care planning, coordination between practitioners, and the evaluation of time to identify the causes of pain that is often needed to manage chronic pain in ways that result in better outcomes. Finalized Healthcare Common Procedure Coding System, or HCPCS codes, for chronic pain management and treatment services support the Healthy People 2030 chronic pain objective, because it ensures that individuals with chronic pain have access to team-based comprehensive management and treatment of chronic pain, therefore improving their quality of care and their quality of life. Next slide. In the 2023 Medicare Physician Fee Schedule, CMS defined chronic pain as a persistent or recurrent pain lasting longer than 3 months. This definition may prompt some practitioners to think that the chronic pain management, or CPM codes, are restricted to established patients, but that is not the case. The 2023 Physician Fee Schedule stated that the beneficiary at the first visit need not have an established history or diagnosis of chronic pain, or be diagnosed with a condition that causes or involves chronic pain. Rather, it is the clinician's responsibility to establish, confirm, or reject a chronic pain and/or pain-related diagnosis when the beneficiary first presents for care and the clinician is using HCPCS code G3002. Also, CMS finalized these 2 codes for bundled monthly chronic pain management, or CPM, services beginning January 1 of 2023. CMS believes that the CPM codes will improve payment accuracy for these services, prompt more practitioners to welcome Medicare beneficiaries with chronic pain into their practices, and encourage practitioners already treating Medicare beneficiaries who have chronic pain to spend the time necessary to help them manage their condition within a trusting, supportive, and ongoing care partnership. HCPCS code G3002 is chronic pain management and treatment by a physician or other qualified health professional, and it requires the initial visit to be face-to-face of at least 30 minutes. and payable once per calendar month. After the initial face-to-face visit, subsequent visits or follow-up care can be done via telehealth as appropriate. When services beyond 30 minutes, each additional 15 minutes of chronic pain management and treatment is supported with the add-on HCPCS code G3003. When using G3003, 15 minutes must be met or exceeded. Healthcare professionals can bill HCPCS G3003, the add-on code, an unlimited number of times as medically necessary per month after the requirements for the HCPCS code G3002, the initial code, have been met and have been billed. Next slide, please. Finalized codes include a bundle of services such as diagnosis, assessment, administration of a validated pain rating scaler tool, development of person-centered care plan that includes goals, clinical needs, and desired goals, medication management, pain and health literacy counseling, ongoing communication, and coordination between practitioners, furnishing care, etc. Clinicians are required to be able to furnish all appropriate elements of the code bundle, but also CMS does not expect that all elements of the code bundle will be appropriate for every patient or every circumstance. Instead, clinicians should perform all of the elements that are appropriate for their patient on the particular date of service. For example, if medication management is appropriate for the specific patient, then a clinician who bills HCPCS code G3002, the initial code, will be required to furnish medication management to that patient, but that will need to take 30 minutes to be certain that the proper amount of time is taken to properly identify the cause of the patient's pain, as opposed to just writing a quick prescription. Next slide, please. CMS is not limiting the number of the type of health care practitioners who can furnish CPM services, as long as they can furnish all of the service elements of the HCPCS code descriptor, including prescribing medication as needed, within their scope of practice in the state in which the services are furnished. Additionally, the rule includes a new pain assessment resources for clinicians page designed by our National Institutes of Health partners among their excellent resources within their pain consortium. The resources were carefully selected as validated and meaningful tools to inform clinicians and patients in sharing decision-making as an aid to identifying the most effective pain management plan for each person. Next slide, please. We will go over some potential cases where the HCPCS code may be used. We have a Medicare beneficiary present for evaluation of our hypertension, diabetes, and chronic pain. The clinician spends 25 minutes on the evaluation and management portion of the service and discuss lifestyle changes related to the hypertension and diabetes. Then she spends 30 minutes on pain management. Can the clinician bill for CPM and the E&M, the evaluation and management codes, on the same day? The answer is yes. If a clinician performs a chronic pain management and standard office visit on the same date, they can report both services as long as the documentation demonstrates that a distinct E&M visit occurred separate from the time documented for the chronic pain management service. Additionally, CPM services may be billed in the same month as remote physiologic monitoring, remote therapeutic monitoring, and care management services such as chronic care management, transitional care management, or behavioral health integration services, if all the requirements to report each services are met. Documentation should demonstrate that time spent furnishing CPM services, the chronic pain management services, was separate from the time spent for any of the other services furnished. Next slide, please. Here's our potential use case number 2. A new Medicare beneficiary presents complaining of lower back pain lasting 5 months, but has never addressed it with a clinician before. If the clinician documents the 5-month duration of the patient's pain and meets the requirements in the code descriptor, is G3002, the initial code, an acceptable code to use? The answer is yes. In the 2023 Physician Fee Schedule rule, we again stated that the beneficiary at the first visit need not have an established history or diagnosis of chronic pain or be diagnosed with a condition that causes or involves chronic pain. Rather, it is the clinician's responsibility to establish, confirm, or reject a chronic pain and/or pain-related diagnosis when the beneficiary first presents for care and the clinician is using HCPCS code G3002. Next slide, please. What are our key takeaways? CMS has defined chronic pain as persistent or recurrent pain lasting longer than 3 months. CMS has finalized 2 new HCPCS codes for bundled monthly chronic pain management, or CPM services, codes G3002 and G3003, beginning January 1st, 2023. The new CPM bundled payment covers integrated multimodal pain care that contains certain elements such as diagnosis, a person-centered plan of care, care coordination, medication management, etc. The CPM services can be billed by a physician or an eligible qualified healthcare professional, and there isn't a limit to the number or type of healthcare professionals who can furnish CPM services. The initial visit under the HCPCS code G3002 must be in person for at least 30 minutes, but subsequent visits may be furnished via telehealth as appropriate. When services extend beyond 30 minutes, each additional 15 minutes of chronic pain management and treatment is supported with the add-on code G3003. And when using the G3003 add-on code, 15 minutes must be met or exceeded. Healthcare professionals can bill these codes, the G3003, the add-on code, an unlimited number of times as medically necessary per month after the initial G3002 code has been billed. And finally, CMS will be monitoring use of these codes to understand more how they're being used. I'd like to thank you for your time today, and I would now like to pass the mic over to Cindy Steinberg of the U.S. Pain Foundation. Thank you. Cindy?
Thank you, Scott. Appreciate it. My talk centers today on 2 essential keys to chronic pain management: best practices and actively involved patients. I speak today from personal experience. I have lived with chronic pain for more than 20 years as a result of a serious accident, and from the experience of knowing well more than 500 people living with high-impact chronic pain. After I was injured, I started a pain support group as a volunteer in my local community, and I'm still running 23 years later. Next slide, please. If we were able to implement the best practices that I'm going to discuss for the medical management of chronic pain, we would make dramatic progress in achieving the healthy people objective of reducing the proportion of adults with high-impact chronic pain. And once we're able to reduce high levels of pain, patients are much more able to participate in self-management. Next slide, please. First, I want to clearly communicate the type of pain that I am primarily speaking about today. This is not a once-in-a-while pain. High-impact chronic pain can devastate a person's quality of life. It destroys your ability to work, to sleep, to socialize, to care for family members, to pursue hobbies, and to find enjoyment in life. It can be described as relentless stabbing or burning or crushing pressure. Some people suffering from chronic pain feel when a light breeze is against their skin as if glass is crashing against their skin. You have the sense of being imprisoned in your body with no means of escape, but I describe it as worse than that because you're imprisoned and you're being tortured 24/7. The WHO has identified chronic pain as a key risk factor for suicide, and the risk of death by suicide is twice as likely in chronic pain versus controls. Next slide, please. The reality is there is no cure given our current knowledge of the neurobiology of pain in the human body, and there's no magic bullet and no treatment that's going to totally eliminate chronic pain. But there are ways to manage it and reduce it enough to have a fulfilling life. How? Through the medical management using the best practices I'm going to speak about and an activated patient. Next slide. The HHS Pain Management Best Practices Interagency Task Force report was delivered in 2019. Next slide. The report was mandated by Congress in the Comprehensive Addiction and Recovery Act. Secretary of Health and Human Services appointed 29 experts. I served on the panel and was the only patient and patient advocate. We spent a year doing an extensive review of research. We received over 9,000 public comments. We had a number of public meetings where we had open public hearings, and a lot of prominent speakers spoke to the group. the commissioner of the FDA, the Surgeon General, most of the doctors in Congress, and the head of the Indian Health Service and others. And our charge was to identify best practices in pain management now, as well as gaps and recommendations to address those gaps. Our final report was endorsed by more than 160 organizations, including the American Medical Association, the American College of Physicians, the American Academy of Pain Medicine, the Association of American Physicians and Surgeons, Human Rights Watch, and many others. Next slide, please. So what is the best way to manage pain now? It's through a comprehensive, individualized, and multidisciplinary approach. By comprehensive, we mean the kind of thing that Scott just described to us, doing a complete assessment, doing a diagnosis, the development and revision, if necessary, of a treatment plan, the facilitation, communication, and coordination with other healthcare providers that are providing therapy as part of the treatment plan. By individualized, we mean every aspect of the care, in the selection and duration of the treatment, in the consideration of risks and benefits, which are different for every individual, as well as in the optimal dosing of any medication. And by multidisciplinary, we mean combining from a full range of pharmacological and non-pharmacological treatments. Next slide, please. So what are those treatments? In the report, we detailed 5 treatment approaches and then a number of treatments within each one. So in medication, we're talking about many different classes and types of medication that are used for chronic pain. In restorative therapies, we're talking about physical therapy and occupational therapy and others. In interventional procedures, we're talking about many different types of nerve blocks to quiet angry nerves, typically delivered by injection, on up to sophisticated medical devices like spinal spacers and implanted neuromodulation devices like spinal cord stimulators. Behavioral health includes things like cognitive behavioral therapy and acceptance and commitment therapy, mindfulness-based stress reduction, and complementary approaches like acupuncture, massage, chiropractic, and others. Next slide, please. So on the left is the beginning of what might be a treatment plan that the patient and physician or nurse practitioner are working on. It includes medication, aquatic physical therapy, cognitive behavioral therapy, and perhaps a walking program. And that suggests to me that might be the beginnings of a plan for somebody with musculoskeletal pain. The idea is that if each therapy that you put into the plan reduces your pain by 10 to 15%, then the combination of 3 or 4 treatments could lead to a 30 to 45% reduction in pain. And the result of that is a huge difference in things that really matter to patients, in your ability to function and in your quality of life. It could make the difference between being able to work part-time or not, being able to play with your children or grandchildren, the ability to go out with friends and enjoy a dinner or a concert or a play. The goal of medical management is to reduce the pain enough to allow active patient engagement. Next slide, please. So the second key to successful chronic pain management is an activated patient. Next slide. Patients who do best with high-impact chronic pain make an important shift to realize their active participation is necessary in managing their condition. But what is meant by active participation? Next slide. There are many skills and ways of thinking and change perspective that go into what we consider active participation. But I believe the 4 most important are listed here: acceptance, pacing, seeking support and connection, and physical activity. By physical activity, I mean any bodily movement that involves muscles and expends energy. Next slide, please. So in acceptance, which some people reach after many years, people call it a journey. Sometimes you go through the stages of grief, grieving for the loss of the person that you once were, and finally arrive at acceptance. It's the realization that there is no cure for chronic pain. And it's shifting your goal from cure to manage. Chronic pain is a condition that you may have for the rest of your life. As I mentioned, I've been living with chronic pain for more than 20 years, and I know many people who have been living with it for decades. It's admittedly a different life from a life that you were expecting to have, but it can still be a good one. You know, you are more than your pain, and it's important when you reach acceptance to realize there are so many other aspects of who you are, your interests, you know, your career, your job, your friends, your family, the things you enjoy doing, your personal characteristics, and that's all part of acceptance. Next slide, please. Pacing is a really important concept for people living with pain. And in fact, I don't know anyone living with pain who doesn't need to limit their activities in some way. You have to essentially track what your limitations are. It could be doing an activity for only a certain period of time. It could be the body position that you're in. It could be the types of activities you do. It could be the amount of stimulation by lights or noise. For example, people living with daily chronic migraine have to limit the amount of light exposure or noise they're exposed to. It's important that you pay close attention to your body's signals to stop and try to not override them. It requires a lot of pre-planning. People with pain often talk about paying for it when you exceed your limits. And it's also talked about as the push-crash cycle. So let's say somebody could only sit comfortably for an hour, but they're watching a, let's say, 4-hour movie or a 4-hour play. And as they sit there, their pain is increasing and increasing, and they're sitting there for an hour and then 2 hours and then 3 hours, and their pain is getting worse and worse till the point when they finally make it home and they crash, and they might not be able to go out for 2 weeks. Instead, what would be really much better is if they sat for an hour and then took a 10-minute break walking around, and then sat for another hour and then took another 10-minute break. So that's what we really mean by pacing your activities. In that case, you could end up seeing most of the entire play or concert or whatever it is you're sitting through and not having to crash when your pain exceeds the limits that you have. Next slide, please. Seeking support and connection is also really important. In fact, the Surgeon General just issued a warning for most Americans that, the lack of connectedness and isolation has caused people to have lots of problems. And with pain, it's that much worse. The loss of your job, your financial independence, your self-esteem, your perhaps role in the family, things you used to enjoy doing, activities you like to do with friends, and your world gets smaller and smaller, leading to extreme loneliness and isolation. Also, the invisible nature of chronic pain means that people are often doubted and stigmatized by doctors or family and friends, which leads to a feeling of being misunderstood and psychologically isolated. I think of that expression, feeling lonely in a crowded room. It's important to find a support group and/or a therapist to help cope with the devastation to one's life and the emotions that accompany the losses. Emotions like anger, fear, frustration, anxiety, and depression. Next slide, please. A support group provides validation, connection, examples of others' coping strategies to model, and camaraderie with others that understand and share your experience. Social connection with those that understand and are empathic is critical to counter this extreme isolation and loneliness that comes with high-impact chronic pain. Next slide, please. Pain Connection is a program of the U.S. Pain Foundation that provides free virtual chronic pain support groups. We have 5 national groups, 19 state-based groups that allow people to develop a local community of support, and 11 specialized groups for special populations. If you go to www.painconnection.org, you can find out and sign up for any of these free groups. Next slide, please. And the last point that I want to make is about physical activity, including exercise and simple movement. And by physical activity, I mean a planned and structured and repetitive program that seeks physical fitness. So participating in some physical activity, especially tailored to your ability and your pain condition, is what I'm speaking about here, like a walking program or simple movement for those who are bedridden, aquatic exercising, using weightlessness to reduce joint, back, and other musculoskeletal pain, or perhaps gentle exercise programs like Tai Chi, Qigong, and adaptive yoga, which are often offered at senior centers around the country, and a core strengthening program, perhaps like a Pilates type program. Next slide, please. How do we make best practice pain care available and accessible? Sadly, very few people with pain experience this type of care. How can we change that? So what's very important is education of healthcare providers and patients, more webinars like this one as a start, and wider dissemination of the HHS Pain Management Best Practices report I talked about, and the educational materials and collaterals that were produced as part of that work. Public and private payers who are willing to cover provider time for more comprehensive care, and for therapies discussed in the report that are not covered or not adequately covered now. CMS has taken a big step in this direction with the new chronic pain management billing codes that Scott just described. Patient support and education model created by the U.S. Pain Foundation is definitely scalable, but will require large grant funding, much like the federal and state grants for substance use for substance use disorder recovery support. Next slide, please. So that concludes my talk. Thanks for listening, and I'm especially appreciative to HHS for doing this webinar in pain management. And now I want to return the floor to Carter.
Right. Thank you. Thank you so much, Cindy, and all of our speakers. I think they're really informative, and I hope helpful to everyone who was listening. So I think we're going into our roundtable discussion. So I'd like to invite all of the presenters, and then June Oliver and Francis Narek. I see you're on too. And Richard, please feel free to join us if you're able. So we have a huge number of questions that have come in, which I think is an indication of the interest in this topic. So I'd like to start off with kind of recognizing Francis and June and get your perspectives on pain management. June, as a nurse, can you just tell us how nurses impact the care delivered to pain patients?
Yes, thank you. Thank you, Carter. And it's so good to be here with all of you today. And, you know, I would say that nurses are well positioned, kind of the boots on the ground, to use a military phrase, right next to the patient. We hear the stories, we see the impact, we're a trusted professional with them. And ASPMN, that I'm part of, American Society of Pain Management Nurses, has been working for over 30 years to educate nurses and to spread that to our colleagues as well as to our patients. And one specific example I could give you is that something we're seeing more frequently in recent years is patients are coming to us afraid to use an opioid, even in a setting where there's an acute extensive surgery that is known to be very painful and they need pain control to promote recovery. We're seeing this in pediatrics as well as adults. And when we share with the patients that uncontrolled acute pain is a risk factor for developing chronic pain, it's new news to most of them and to many of our colleagues. And so that's one slice of education that nurses, especially pain management nurses who have extra skill and training, are sharing in trying to improve the lives of our patients as well as prevent ongoing morbidity.
Hope if I get off mute.
Mhm.
So thanks, June. And Francis, Cindy mentioned the benefits of physical activity to manage pain. So given that we've heard about the value of physical activity and exercise to manage chronic pain, in what ways do you see exercise physiologists helping people better manage their chronic pain? And how can we make this more accessible?
Yeah, that's great. That's a great question. So I think a lot of folks who are experiencing pain, I don't think realize that in exercise or physical activity is one of the things that you would want to avoid, but it actually really provides a lot of pain relief, and through the natural release of endorphins, reducing inflammation, improving flexibility and your quality of sleep. It really kind of all works together. I think one of the big things is being able to work hand in hand with the healthcare team. And to really kind of create individualized plans for those patients, and being able to share information back and forth between the exercise professionals and the healthcare team to really do a patient-centered approach. I think that's one of the biggest things to do that. Depending on the complexity of the condition, sometimes when you're looking at exercise professionals, they're not a monolith. And so I would look for folks with especially more complex conditions to look for somebody with maybe a degree in the field. In addition to being certified. I think those are one of the big things. And really registered exercise professionals are the ones who are part of the healthcare team to help those patients really kind of improve their chronic pain.
Great, thank you. And Richard, June did mention pediatrics, but most of our presentations did focus on adult chronic pain. Can you tell us what is known about chronic pain in children and treating it?
Right. Most national surveys don't ask children chronic pain questions for whatever reasons. It's you theoretically they could be using the happy face scales, but they don't. So when epidemiologists are looking at chronic pain in kids, what we have to do is use clinical classification codes or ICD codes to identify, as I was doing before, for the MEPS data, identify health conditions that are likely painful. And so we have published studies looking at musculoskeletal pain this way. And in fact, the data I showed you in MEPS, looking at the different health conditions, we did the same kind of thing, comparing musculoskeletal pain in children to, if I remember right, anxiety, depression, otitis media, asthma, and ADHD. And what we found is it really varies on what age group you're looking at among children. I mean, children go from 0 to 17 nowadays, and 18 being adults. So if you look at the very youngest children, under 12, then you don't see much musculoskeletal pain at all. But then if you bump up to the 13 through 17-year-olds, you see a very large jump in musculoskeletal pains. But conversely, infectious disease, like something you might get with otitis media, that's very high in children, younger ages, but then it drops really low in the adolescent teenager years. So it's, we're trying to do some follow-up studies on this, but it's difficult to know what age groups to look at because the data is so different depending on what age groups you look at. And it makes the papers very complex if you show multiple age groups. So we're thinking on our next study. One thing I will point out is that we looked at a lot of treatments for chronic pain, this musculoskeletal pain in children. Not unsurprisingly, the highest use of drugs was for NSAIDs or Tylenol in children. But yet in this adolescents, teenager group, there was surprisingly high use of opiates. And we, in our paper, we basically said there's no data supporting opiate use for musculoskeletal pain in this population. And that was shocking. And so we definitely want to do a follow-up study looking at trends of opiate use in this adolescent group. And maybe in a few years, we'll be ready to present that.
Great, thank you. So we'll be on the lookout for that. Christina, there were many questions that came in about the new CDC guidelines. And I think a few dealt with how can physicians kind of reset when they've been following the 2016 guidelines. And then there was a comment that CDC did have an excellent training on the 2016 guidelines online. And there's a question, will you be doing the same thing for the new guidelines?
Sure, yeah. Thank you for those important questions. So I'll tackle the first one first regarding a reset. And just to clarify, I'm guessing this is probably a question around how to incorporate the updated guidance from 2022 compared to 2016. What I will say, there are some overarching themes as it relates to chronic pain from the 2016 guideline that still are supported by evidence and or a part of the 2022 CDC guideline. However, there are certain aspects of what was in the 2016 guideline that may have been misapplied or misunderstood and have been rearranged and really elevated in the 2022 clinical practice guideline. And so I think we talk about a reset. I'm not sure if that's what you're getting at, but I think the 2022 update really focuses on where the evidence has gone since the 2016 guideline was released, and really trying to do what we can via the guideline to ensure that there's access to effective, safe care for patients with pain. Now, what I will say with regards to trainings, because I think that's a part of that, right? A guideline is just a guideline, but if clinicians and health systems aren't incorporating this into practice and making it a part of their workflow, then it's not actually getting to the part of application and conversations with patients. And so I think that the educational part that you were speaking to is a part of what we're working on to disseminate the guidance in the 2022 guideline. So there were trainings related to pain on that were released after 2016. If anyone has navigated to our website, perhaps via the link that was posted before, those trainings have been taken down simply because they're being refreshed with more of a focus on the 2022 CDC clinical practice guidelines. So they're coming back. It's just they're in the midst of being updated to reflect the updated guidelines. So what I highlighted during my presentation was the first one that was put out that was really geared towards clinicians and providing an overview of the guideline. But there's more trainings and modules and web content related to other aspects of pain care, including chronic pain intended for clinicians, and also some materials for patients as well, to really help them partner with clinicians and be an advocate for their pain care. Thanks for that question.
Okay, great. Thanks so much. And then Scott, there were also many questions about helping providers understand when to use codes, how they can use them. So what are CMS's plans for further educating primary care providers on the use of the new codes?
Thank you. That's a great question. So CMS has what's called the Medicare Learning Network that provides educational materials for healthcare practitioners and the public on many of our programs, policies, and initiatives. Currently, CMS is working on the possible creation of some chronic pain management Medicare Learning Network fact sheets and booklets. They'll provide practitioners with information such as the type of practitioners who can provide these services, the elements of the bundled service and the code descriptor and billing tips, et cetera. Additionally, the Medicare Administrative Contractors, or MACs, the people who administer Medicare for us, have been given instructions to help provide education materials regarding these codes.
Great, thank you. And we are really running down to the wire, but Cindy, the people seem to love your concept of pacing. But we have a question of a lot of people in the audience may have a loved one or being caring for someone who's experienced chronic pain. So do you have any words of wisdoms for all those people, how they can support their loved ones?
Yeah, great question. So first of all, empathy. A little bit of empathy goes a long way. And I would say to the caregiver or the person that is talking about the loved one, think of the worst pain you've ever had and imagine if that just kept going on and on. So, empathy really helps. Also, just carefully observing the cues of the person living with pain, because people often show, like rubbing their side or wherever it is that hurts, and then help them to pace, encourage them to rest when you see them, indicating that they're living in pain. Accompanying them to doctor's appointments is also really helpful, so you can advocate, and then helping them find and research treatments and support groups is what I would recommend.
Great, thank you. And you know, we are at time, but if you want to throw up our last slide, our kind of parting slide on Healthy People Champions, we did have a question from someone in the audience who happens to be a Healthy People Champion. It's the Massage Therapy Foundation. And they actually asked what they could do to help promote the health progress toward the Healthy People objective. So I think the role that Healthy People plays with our national objectives is to give organizations, advocates, whomever, a common goal to strive toward. So if we all work toward reducing chronic pain and incorporate those messages and all the points that we learned today into what we do, we could all, I think, help the nation address this issue in a meaningful way. So with that, I think that's a wrap. I wish we had decided to go longer with this because there's so many more questions that we'd love to get to. But thank you all for joining us, and we'll
Thank
join
you
you in
very
another webinar.
Thank
Thank
you.
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 Bye-bye.
Bye.